Good evening, everyone. Thank you for joining us tonight. My name is James Galt, and I run product development at Flora Medical. We are a foot and ankle company dedicated to advancing minimally invasive solutions. It is my pleasure to introduce Dr. Holly Johnson, who, as you all may know, is very well respected as a thought leader in the MIS community. Dr. Johnson was one of the three designers on our minimally invasive plating system for MTP fusions, which she'll be discussing tonight. And her expertise in MIS was critical to us developing a successful product and technique. Dr. Johnson practices at the Hospital for Special Surgery and is also the team physician for the New York Rangers and the New York Liberty. We're extremely passionate about MIS. I'm excited for this presentation. Tonight, Dr. Johnson will discuss a brief history and overview of MIS, its evolution, its benefits, and then hone in on MIS MTP fusions and why plating is so advantageous. We'll have a Q&A session at the end, and feel free to post your questions in the chat. In the meantime, if everyone could now post in the chat where you're joining us from, we'd love to see. And with that, I'll pass it over to you, Dr. Johnson. Thank you.
All right, great, James. Thanks so much for the intro. And as you mentioned, I'm going to go through a history of percutaneous surgery and then transition to the MIS treatment of hallux rigidus. All right. So I just want to say ahead of time that a lot of these slides were adapted from my good friend, Dr. Eduard Rabat from Spain, as well as slides that have been in the MIFAS, the Minimally Invasive Foot and Ankle Society. That's an international society for years. So some of these are my slides, but a lot of them were adapted from my colleagues. So minimally invasive surgery, or really subdermal surgery as it started, really began in 1945 by a podiatrist, Morton Polikoff. And he developed these chisels and wraps and had some galvanic power for exostectomies to take care of, nail issues and such. And then from the 1960s to 70s, this instrumentation was advanced to more like rasp, power rasp and burr type designs to help with more bony cuts and exostectomies. In the 1980s, Stephen Isham, who is a podiatrist in the US, really tried to move forward percutaneous surgery. And he developed a procedure called the modified Reverdin. And this was the Reverdin was an open procedure that had been around for many, many years to treat bunions. And basically, it was a closing wedge osteotomy of the first metatarsal head. But he learned how to do it percutaneously. And this and other procedures he taught to colleagues, not only here, but over in Europe. And so he set up a course in 1995. He had many courses over the years, but in this particular course in 1995 in Madrid, he met a fellow foot and ankle surgeon, Mariano del Prado. Mariano was a great foot and ankle surgeon who was really inspired by Stephen Isham's use of percutaneous surgery, and they became really good friends and started exchanging ideas and techniques. And this really launched a lot of the interest in MIS and percutaneous surgery within Europe. So then Mariano del Prado partnered up with Pau Galano, who was a master anatomist who sadly passed away at a young age. But Pau and Mariano really developed the anatomic and technical foundation for percutaneous foot surgery. So Mariano would do the surgical part, and then Pau would do these incredibly intricate cadaver dissections to try to better understand how the burrs worked in the soft tissues and in the bone, and really how it affected the overall anatomy. From 1997 to 2014, in fact, Del Prado and Pau had a percutaneous course at the University of Barcelona, and that continued for many years. Again, this is a very well-known cadaver course and really furthered percutaneous surgery within Europe. Well, meanwhile, Del Prado and others extended percutaneous techniques to North America, Central America, South America, Italy, and all over Europe. Now, meanwhile, back in the United States in the 80s and 90s, Stephen Isham tried to popularize the modified Reverden, this, as I described before, intracapsular technique, but with no fixation. And unfortunately, there were a lot of complications when others tried to do the surgery themselves. These included avascular necrosis, significant shortening of the metatarsals, really average of 5 millimeters. And unfortunately, the results of Isham's paper that he published were not really reproducible by other surgeons within the US. And it became more of a skeptical type procedure technique in the US. In the 2000s, the techniques advanced in Europe, and in Italy specifically, Giannini and his colleagues developed a modification of the Bosch technique, which is basically a percutaneous subcapital osteotomy, as you see in the picture, fixated by a single pin. And patients were allowed to ambulate immediately. The pin was pulled at 6 weeks, and Giannini and his colleagues reported excellent results of this. However, again, when others tried to do these procedures, there were delayed unions, non-unions, avascular necrosis, stiffness of the first MTP joint, and a significant number of pin complications. Well, going back to the US, Mark Meyerson had many international fellows over the years and had met a lot of the leaders of percutaneous surgery in Europe, and they came and visited him and taught him some techniques. So he tried it himself with some of his fellows. And unfortunately, after trying to adopt a minimally invasive technique, it wasn't a true percutaneous technique. He published really dismal results on just 13 patients, and he abandoned the procedure because he had significant complications in just this small amount of patients, and basically ended up with the conclusion that they could not recommend the procedure. And so this completely closed the door on MIS and percutaneous surgery in the United States for really 10 years. It's important to note, though, that for this paper, the technique was not the percutaneous technique that others were doing in Europe. It was performed with a saw, it was minimally invasive, and it was different. And so the failures can't necessarily be associated to the specific percutaneous technique, but more the technique employed by the author of the paper. So meanwhile, while the door was shut in the United States and Europe, percutaneous surgery continues to progress. 3 French surgeons started Gretmic, which is now called MIFAS, in 2002, and now it's grown to over 1,000 international members. There are yearly basic and advanced courses. I host one with Becky Serrato in the US every year, research grants, and it's been an incredible group that's been teaching percutaneous surgery really all over the world now for many years. Probably the most important advancement in percutaneous surgery in terms of bringing it to the United States was when David Redford and Joël Vernois developed their MICA technique. They published improved results with percutaneous techniques, and essentially what they figured out was how to get excellent percutaneous correction with good fixation. And so it allowed reproducible results. And I can tell you for now, we've come a long way since the MICA in 2017. And pretty much every company in the US, every foot and ankle company has their own version, not only of a minimally invasive bunion, but now Lapidus, Bunionette, and now first MTP fusion. So we've come a really long way. And finally, the US is starting to take the lead in some of the percutaneous advancements. So I'm going to switch gears here a little bit and talk about MIS solutions for hallux rigidus. I'll briefly talk about chilectomy and first metatarsal osteotomy, and then focus on fusion. So I love percutaneous chilectomy for patients who have a large dorsal osteophyte, but don't really have a lot of joint pain per se. And we could have a much longer discussion about the indications for chilectomy that I'm not going to really go into. But for me, once a patient's indicated for chilectomy, I always choose to do it minimally invasively. And through this small incision, I can get patients. Sometimes I make a second incision if I need to, but in 20 minutes of surgery with immediate weight bearing, no narcotics, they can transition back into a regular shoe at post-op day 3. 3 and are really back to full activity after that. It takes runners about a week and a half to get back to running. And generally speaking, by 4 to 6 weeks, it's like we never did surgery. So I think that percutaneous chilectomy has a ton of advantages. I'm happy to continue to pontificate at another time if anyone wants to hear about it. When I have patients who have hallux rigidus without significant spurring, but a long first metatarsal, and they have preserved range of motion of the MTP joint, I've been doing first metatarsal shortening osteotomies with some plantar translation, and I've really had excellent results with this. My indications are very rigid right now. They need to have a long first metatarsal, and they need to have good range of motion and joint space preserved. I add a Moberg to this about 25% of the time, but oftentimes I don't need to. And for the past 3 years, I've been doing this. More recently, a few more, and hopefully I'll have enough data to publish. This is another example, but I've really had a lot of success maintaining range of motion and hopefully in the end demonstrating that this can preserve some joint space for patients. So getting on to MTP fusion. So for me, my indications for fusion are really patients with hallux rigidus who have a lot of stiffness. I found that patients who have range of motion beyond about 20 degrees, at least in my practice and my practice population, are not as happy with fusion and really don't even want to talk about it. So for me, it's patients who have stiffness. They not only have pain in shoes, but they have pain barefoot, telling me that not only do the dorsal osteophytes hurt, but also the joint itself hurts. And I make sure that the expectations of surgery are well understood by the patient. I'm basically going to turn a stiff, painful big toe joint into a stiff, non-painful big toe joint. And I try to be really clear about that. I am willing to try chilectomy first on some of these patients, but generally when they fit the 3 top criteria, we're going on to fusion. So how should we be fusing the joint? Well, there's been a decent amount of data looking at different types of fixation, locking versus non-locking. How do you prep the joint? Do you do flat cuts? Do you do cup and cone? What materials are you using? Titanium plates, stainless steel plates, whether you're using a locking plate or a non-locking plate, interfrag screw, non-inter, or just the plate alone. The post-op protocols vary. A lot of these are cadaver studies with different protocols to demonstrate whether or not there's enough stiffness or whether there's plantar gapping or not. And so it is hard when you really look deep into the data how to interpret the results because they're really heterogeneous. But what I feel like after doing a deep dive into this over the past week or so is that the current consensus is that a dorsal locking plate with a lag screw is the strongest plate construct and most likely the strongest construct overall. And I think that this has really been borne out in the literature. If you look through all the papers that have been published probably in the last 15 years. There's one study that Ken Hunt and his crew did with Alistair and others that is a really nice biomechanical comparison looking at the sort of current low profile contoured locking plate with a single compression screw, comparing that to 2 fully threaded screws. And what they found in this study was that actually this study in particular, the screws tended to have a higher load to failure and more stiffness, but with osteopenic bone, they trended towards a higher failure rate. So I think what you can take away from this is that most likely the dorsal locking plate and crossing screw is the strongest construct. Certainly an osteopenic bone, which most people that were fusing, at least in my practice, tend to have osteopenic bone. But that the crossing screw technique is a viable option if the plate is not an option. So what about the outcomes of MIS fusion? Well, these are scarce studies. There really aren't that many, and they're only looking at screw fixation. We don't have a head-to-head study other than the most recent one that came out by Chris Miller. A lot of the studies that are out there are really just looking at retrospective data, looking at fusion and complication. And generally they have very good results, comparable to sort of modern day open techniques. Chris Miller's study that just came out in FAI a few months ago basically demonstrated equal fusion rates and equal complication rates looking at MIS versus open. But what they were unable to do in this retrospective study was look at the early results. And I think that for me, when we look at MTP fusion at a year, patients are probably going to be similar whether you did it MIS or open. But when you look at the first 3 days, the first 2 weeks, the first 3 months, that's really where you're going to see the difference. And you're going to see in the first 3 days that the MIS patients don't take any pain medication beyond, ibuprofen and Tylenol. You'll see that at 6 weeks, the healing is far faster, not only with the bone, but really the soft tissues. The scars are healed, the lesser toes are moving better, the foot just looks like a more normal foot. And you'll find that by 3 months, the MIS patients are back to full activity. Their surgery is behind them, whereas the open patients are still struggling with scarred down incisions, general swelling, some pain and aching. And so I think it's going to be really important to get a head-to-head study looking at those early results, just the way I feel the same way about looking at MIS lapidus or MIS distal bunion correction as well. So, and then it's just so hard when you look at these images. These are not old-fashioned pictures. These are current techniques. This is a bone block arthrodesis in the center, but the cup and cone reamer pictures to the left. It's just how could that be better than doing the surgery through these little tiny incisions? And these two bottom pictures are Jesse Doty's pictures where he's using Dermabond to close the wounds. He doesn't even use nylon sutures. And so it's so hard for me to hear an argument that doing a gigantic open approach is better, even long term, than not disrupting the soft tissues, not taking down the blood supply, getting the tendon all cut up in scar tissue. How could it be better to do it open than MIS? I just fail to see that. So let's talk about the technique of plating. So it is challenging. And I think that you really have to be comfortable with the burr. You have to be comfortable with your percutaneous fixation techniques. But once you become comfortable with the burr, I think it's reasonable to take this on. So the first thing I do is I do the cheilectomy. Pretty much every first MTP joint that we're fusing is going to have large dorsal osteophytes. So I make a small dorsomedial incision that you can see in the upper right. I spread down to bone, I elevate the capsule, and I lift up the capsule to create space for the plate to lift the EHL up to make sure the nerve's out of the way. And you basically create this working space within the capsule to get the job done. I use the 3x13 wedge burr to debride the osteophytes and as well to take down the dorsal joint. And this is important. When I used to do this procedure open, I would take my saw and make sure that the top of the joint was flush. And similarly, when I do it MIS, I want to do that as well so that the plate sits nice and flush along the dorsal aspect of the bone. So after I've done the cheilectomy, I prep the metatarsophalangeal joint. And generally I'm doing this through a medial incision that goes right into the joint. For me, I start with the 2x10 burr to create a little space, and then I use the wedge burr, the 3x13, to get in and really debride what's left of the cartilage. I will often make a small dorsal incision along the dorsolateral part of the joint if I feel like I need to use my curette for fine tuning and to check and make sure that I've gotten all the cartilage out. And then it's absolutely critical to get all of the debris out of the joint. And what I do is I take a 14 gauge angiocath and I irrigate probably 20 times worth of 30 cc's of fluid. And I just run it through there and flush everything out. I use a pituitary to grab any larger chunks of bone. And I make sure that there's nothing that's going to create a block to compressing the joint or leave any debris dorsally that could cause any irritation. You can use a distractor if you want, and this actually comes on the Formaset. If you feel like it's easier as opposed to holding the toe, I usually use manual traction now to hold the toe, but this distractor does create more of a, it frees up your non-dominant hand to manipulate the foot a little bit more, and so it can make things easier. In addition, people often ask me, do you do flat cuts or try to maintain the shape of the metatarsal? And for me, it really depends on the metatarsal head. If it's super flat, then I do flat cuts. If it still has good contour, then I keep the contour of the joint. And in that case, that's when I use my curette a bit to make sure that in the deep recesses of the joint, especially at the proximal phalanx, I've been able to get all of the remaining cartilage out. If I do it that way, I keep the subchondral bone intact. I usually place a little bone graft in the joint, and then I reduce and pin it. And you can pin it with one crossing K wire, which is usually how I do it. You can put two in if you feel like you need a bit more stability. And at this point, if I were placing two crossing screws, I place the screws right over those wires and get my joint nice and compressed and held. I'm usually holding manual compression as I place the wire and then as I place the screw. When I'm using my plate, I place a wire, and you can place the interfrag screw or compression screw before you place the plate or after you place the plate. And that's really dealer's choice. I think that for me personally, I like to do the plate first and then place the screw, but I think that either technique is fine as long as you're getting enough manual compression when you do it. This is my 2-screw configuration, which I sometimes use, but when I'm worried about the bone, particularly an osteopenic patient, I will definitely opt to use a dorsal plate. And these are the Forma plates. There's a left plate and a right plate with this nice contour. And you can use the left plate for the left or right foot. And a lot of times I'm looking at the anatomy of the first MTP joint. Once I have my provisional fixation in with the wire to see where I have the most space, where the holes are going to be, and then where I can place my screw. So, if I'm using the proximal holes in a more lateral position, I'm most likely going to place my compression screw from proximal to distal so that I get enough bone. And the opposite is true if I'm using a right plate. That's usually my configuration, but you can certainly place your compression screw distal to proximal. It's really dealer's choice. But for me, it's really where I have the best bone quality that I think I can not only have the plate, but also that extra screw. So when I'm placing the plate, I place the plate on top of the skin and get a fluoro view just to and I outline it with my marking pen just to kind of get an idea of where the plate's going to be. Then the incision where I did the chylectomy, I extend to be about 7 millimeters. And through that, I can slide the plate right underneath, of course, making sure it's under the capsule, under the EHL, and is sitting flush on the bone. You secure the plate percutaneously through the jig with a proximal wire, and then I usually place a distal wire outside of the plate. You can see it in that top image, just to sort of keep the rotational stability distally. Then I place my distal screws and I make a small incision using fluoroscopic guidance, about 5 millimeters, directly over, it's sort of in between the two screw holes. And that allows me to put one screw in, and then I take my threaded guide out, I do the next screw, and I can do it through this small incision, just simply moving the skin out of the way and keeping a single small incision. If I place my distal screws, sometimes I'll place my compression screw after that. So I'll sort of position the plate and then I'll get my screw and my compression in, and then I'll put in my proximal screws. But again, it's dealer's choice when you want to place that interfrag screw. Then I remove the guide and I place my proximal screws. These two pictures came from Jesse's case, and through this proximal incision, that's where the proximal screws are going to go. At the end of the case, always double check that the EHL is moving well and hasn't been in any way adhesed down by the plate or a screw edge or anything else. And this is what it looks like afterwards. You have your dorsal medial incision where you place the plate, the distal incision where you placed your two screws, my medial incision where I prepped the joint, and then this is where I placed my screw outside of the plate. This is a same case example, or sorry, different case example, a 64-year-old, obvious, good indication for surgery. And then this is what it looks like postoperatively. You can see how great it looks at 6 weeks. There's minimal swelling. You can barely see the incisions, and the patients do great. And this is a 6-week X-ray, which to me looks pretty darn good for 6 weeks. This is another case of Jesse's where he was able to do a pretty significant deformity minimally invasively. I think these are really challenging cases, and definitely one where I would not feel comfortable with 2 screws. I feel much more comfortable not only holding the deformity, but getting compression and stability, adding the dorsal plate. So my post-op protocol often depends on bone quality. So if I have a patient with pretty crummy bone, I'll keep them non-weight bearing for about 2 weeks. If the bone is in good quality, I'll let them put a little heel weight bearing on it in a boot. So they're basically, they can start weight bearing as tolerated after the first 2 weeks in the boot. They're in the boot for 8 weeks, and then they can transition into a sneaker and a stiff-soled shoe. And then after 12 weeks, they're back in anything they want without restrictions. So just a couple of thoughts in conclusion. MIS fusion is feasible. You can use different techniques. I think the plate offers another option for really better fixation, especially in osteopenic bone, and just gives a little bit more peace of mind for these fusions, but still allows that faster recovery with minimal pain, which is clearly the biggest advantage, in my opinion, of MIS surgery. Thank you. And does anyone have any questions?
That was fantastic. Thank you so much, Dr. Johnson. We got a couple questions here. So we got one from Dr. Bazrafshan in Chattanooga. He said, you had mentioned you place a bone graft after joint prep. Can you elaborate briefly?
Sure. For me, I usually use a demineralized bone matrix putty that has some live cells in it. I think you can use whatever you want. I use a lot of bone graft for any fusion. I'm using bone graft, but that's usually what I use.
Okay, great. We've got another question here. I'll read this out. It says, the procedure makes sense. However, what is the difference in making a moderately small incision over the joint as opposed to 2 smaller incisions for the locking screws for the plate construct? Why not just open it up with a mini open incision?
I think it technically is kind of a mini open incision, right? When we think about percutaneous means poke holes. So when we talk about percutaneous surgery, that's literally poke holes. When we think about minimally invasive, it's through a small incision. And I think that I think the person's asking, do they, making a small incision directly over the joint? If you're going to place a plate, though, I don't know how you get distal and proximal screws in through one mini incision in the middle. Am I understanding that, James?
I think so. I think it's maybe an air quotes mini open procedure, just enough to get to a traditional plates, distal and proximal locking screws.
Yeah. Well, I think that I see what you're saying. So say you want to prep the joint, you don't need to do the big cup and cone reamer thing, laying open the entire joint. But in order to get the joint open enough to get all the cartilage out, you still have to release a decent amount of the of the capsule. The length of the plate in order to get the screws in without putting it percutaneously, I think the length of those plates, if I'm like looking at my hand, thinking about it, is about 2 inches. So I don't know how you get the plate in and get the screws in without making a larger incision, at least the length of the plate. Um, but look, I think if you feel comfortable with that, any small incision is going to be better than a big incision, and less soft tissue stripping, particularly medially, laterally, and plantarly, is going to have a faster recovery. So if that's sort of your first foray into minimally invasive surgery, I think that's great. And if you're someone who doesn't use a burr comfortably and you want to try a small incision technique without using the burrs, I think that's definitely a great place to start.
Absolutely. Yeah, we've definitely seen that on new users just to get comfortable with it.
Yeah.
All right, we've got a couple
And
more
then
questions. Oh, yeah.
one other point on that. The other thing is, if you're new with the burr and you're questioning whether or not you can adequately prep the joint, you can make the two MIS incisions. So the one right at the medial joint and the dorsal medial one, and do your joint prep, and then you can make your mini incision on top and kind of see how you did. And what you'll find is the more you do, you'll realize that you're actually prepping the joint quite well, and you don't need to make that dorsal incision to check. That's how I started doing it, actually. So I think that that's a really nice way to kind of practice in a safe way.
Right. Absolutely. I love that. All right. We got a question here about setup for the case. Just a question about what kind of prep you do with the knee, what size C-arm you use, and then is the assistant there holding the leg similar to the MIS bunion setup?
So it's a great question. So I set it up very similar to my MIS bunion, and the you don't necessarily have to have the foot off the bed, but you need to have the operative foot propped up compared to the contralateral leg, because I'm going to try to demonstrate this. If this is where your sort of point of entry is with the burr, you need to be able to move your hand and an arc. And if you're hitting the bed on the plantar and the body, when you're trying to get the dorsal aspect of the joint, because the bed's in the way, that's going to be a problem. So
Right.
that's why for me, it's easier just to have the foot propped up a little bit and off the bed so I can really get the arc of the burr. I use a mini C-arm, and I use it on the right. I'm a right-handed surgeon. I keep the mini C-arm on the right side of the table. And I don't really I don't really need an assistant for it per se for the prep part, but oftentimes if I have an assistant while I hold the reduction, I'll have somebody fire the wire for me because I find that sometimes it's hard to hold your reduction and get your provisional fixation. I don't know, did that answer the question? Hopefully that answered it.
Absolutely. Yeah, Scott, please follow up if there are any other questions on that. And then the last question here, why flush the joint? Would you consider leaving the bone paste in? I would say, just to add to that, we have heard some surgeons prefer to leave it in. Some surgeons like to just remove the cartilage, leave less of the rest of the bone there in thinking that it supports healing. What are your thoughts on that?
So to be honest, that's a really, really great question. And I don't have a scientific answer for it. Um, I think we would need to look at the material, sort of the subchondral bone, at the cartilage remnants. To me, I don't want any remnants of cartilage in the joint because I worry that could hold back my fusion. So if I'm going to leave bone in there, if I were going to go in and drill it, or if I were going through the subchondral bone, then I would leave any bone. But what I don't want is sort of dead sclerotic bone. I don't want any remaining cartilage in there. And along the dorsal aspect of the joint, when I'm doing the chilectomy, a lot of times there's capsular remnants in that, and it sits on top of the joint. And I think that can be an irritant for people on the dorsal aspect of the joint. So for me, I like to flush it, but I can't tell you with any scientific certainty that that's the right thing and that we shouldn't just be debriding cartilage and leaving it in the joint.
Okay, great. All right, so that concludes all the questions. Thank you all so much for joining us this evening. Thank you very much, Dr. Johnson. I hope you all
Sure.
enjoyed the presentation as much as I did. It's really amazing to see the results you can deliver, especially compared to the current open technique. So this recording will be live on our website next week, and I invite you to follow Forma Medical on LinkedIn. We're active with our posts on latest news, updates, product launches, etc. So follow along. And thank you all for joining again. Have a great evening. Thank you.
Bye-bye. Thank you all.